down on who we have checked in, and then we'll kind of go through, since this is the first time we've got all the board on the phone, see if we can do this in a reasonable semblance of sanity. So how about if I go down the names that we list, and then we'll go through those that aren't called in on the phone and see, because it looks like we have a quorum. So, and if you're not online on the phone, if you can just chat to us that you're here when we go through. So I see Carrie Green. So Carrie, can you hear us, and can you chime in? How about Dan Ferguson? Either speak up or type something in the chat box that you're here and on board. Holly Seiler, Holly's not a board member, is she?
No.
Okay. So what about Kathleen Juris?
I'm sorry, I missed the question. This is Martha.
She's not a board member. Yeah. I'm looking for board members.
She's not a board member.
Okay. Madeline Carlson?
Yes, I'm here.
Madeline, are you? Okay, thank you. Madeline's here. So Rhonda, I'm here. Ronnie?
Yes, I'm here.
Ronnie's here.
That's Brian.
Brian. Samantha Frederick?
I'm here, but I'm not a board member.
Okay. Sandra Suarez?
I'm here.
Okay, thank you, Sam. Sandra. Okay, so I'm going back up. We've got several callers that are just listed as callers that didn't put in pins. So board members that have not announced themselves, could we go through and have you do that, please?
This is Darlene Darnell with Catholic Charities.
Hi, Darlene.
Brian Gibbons.
Brian.
Yeah, Thornbrew with Comprehensive Healthcare, and unfortunately I'll have to drop at 1 o'clock.
Okay, thank you, Ed.
Dan Ferguson.
Thank you, Dan.
Oh, Dan Ferguson.
Yep, got it.
Okay.
This is Martha Landman. It's calling me in as Kathy Juris. I don't know why that is.
Okay, thank you, Martha. Okay, any other board members on the call? And Carol or Ashleen or whoever's taking minutes, can you tell me if that means if we have a quorum yet?
We do have a quorum. We have 9 people.
We do. Okay, great.
Yes.
So that's great. Okay, so are there any, so if the guests that are on the call, could we just, for the roster, could we have you announce yourself, please?
This is Corey Blythe with Southeast Washington.
Thank you, Corey.
Holly Seiler with Second Harvest.
Thank you.
This is Samantha Frederick with Quality Behavioral Health.
Thank you.
This is Courtney Ward with Amir Group.
Thank you.
Troy Henderson, Whitman County.
Thank you.
Jorge Rivera, Modena Healthcare.
Thank you, Jorge. Any other guests on the call that have not announced themselves? Okay, any other board members on the call that have not announced themselves? All right, so this is our first call where we've had everyone remote. So just in terms of keeping the communication going, what I would ask is that we go through the agenda and people have comments or things they want to share. If you could just say your name, and then I will keep a list of who's in the queue to speak. And then as we have opportunities, then we'll just go in order of those that have announced themselves in the queue. So hopefully that will sound okay to everyone. We don't have a long agenda today. We'll start by going through and having each of you, if you would please, just review the attestation of the conflict of interest and the self-dealing transactions, the prohibition and standards for approval. So I'll give you just a minute to read through that and refresh your memory on our conflict of interest policy. And I see that Caitlin Safford has just joined the call. So welcome, Caitlin.
Hello.
Hello, thanks for joining. So then the first...
Ruben Alvarado is here as well.
Oh, great. Thank you, Ruben. So just for your information, we do have a quorum on the call. So the first thing we're going to look at is the board meeting minutes from the June 21st meeting, and this is on the consent calendar. So it's the only thing I think on the consent calendar. So hopefully you've all had a chance to look through those. These were sent out a while back. So I would ask for those that have had a chance to read through these for a motion to approve or amend or change the minutes.
So Rhonda, this is Carol, and I see that on page 4 at the very bottom of the page on the right-hand column, we failed to change Ruben Peralta to Ruben Alvarado, but we will do that on our copies.
Okay.
I had noted that before, and we just failed to change it here.
Okay, thank you.
Too many Rubens.
This is Sandra. I motion to approve the minutes with edit.
Thank you, Sandra.
This is Ronnie Batchelor. I second.
Thank you, Ronnie. Is there any further discussion on the minutes? With none, all those in favor of approving the minutes?
Aye.
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 No laggers, please. This is tough on the phone. Is anyone opposed to the minutes? Okay, the minutes are approved. Thank you very much. So the next item, which you've got the agenda covered up for me, so I'll pull it up. So I think is the director's report or the staff report, Carol?
So the next thing is the meeting our new staff members, and I've asked both Becky and Martine to say a little bit about themselves.
Great, okay.
This is Martin Sanchez. I come from Virginia Mason Memorial. I worked there for 4.5 years coordinating a childhood obesity program and facilitating diabetes prevention classes and chronic disease self-management classes out in the community, as well as doing community outreach. And this is completing my second week of work here.
I'm Becky Colm. I come from Energy Northwest as a contract officer, and before that I was at Grant County PUD as a contract officer. And Martine and I started the same day, so we're 2 weeks.
And they're swimming.
Okay, well, welcome, Becky and Martine.
Thank you.
Thank you.
We'll look forward to meeting you in person. Okay, I think we're on to the recommended practice transformation action items.
Right, and so this is Carol, and I asked Lauren to send out the written version of what I'm going to read to you. I just wanted this to be very succinct and logical, so everybody should have in their email an item that's called Introduction to July 19th Agenda Item, the process to recommend clinics for practice transformation. So as you know, Greater Columbia has embraced practice transformation and more specifically the patient-centered medical home model of care as the foundation for transforming our regional healthcare delivery system. The PCMH model of care is a strategic way to strengthen primary care, improve reimbursement for services, and will help providers be successful in value-based payment contracts. Thus, it provides stability beyond the life of the Medicaid waiver. The PCMH is a model for comprehensive, continuous patient-centered, team-based, and accessible primary care delivered in the context of a patient's family and community. The PCMH model also aligns closely with our 4 project areas. PCMH models of care are bidirectional and integrate behavioral health with primary care. PCMH models of care focus on prevention and treatment of chronic disease. The PCMH plus the transitional care model targets chronically ill adults and high-risk, high-utilizing patients. The 6 building blocks is a team-based approach to improving opioid management in primary care and incorporates the PCMH change concept. The McCall Institute has developed a PCMH change concept model, the PCMH-A, which is an assessment tool that's driven by change concepts. We define change concepts as a general idea with proven merit and a sound scientific or logical foundation that can stimulate specific ideas for change that lead to improvement. The 8 safety net medical home, patient-centered medical home change concepts include engaged leadership, quality improvement strategy, empowerment, continuous and team-based healing relationships, organized evidence-based care, patient-centered interactions, enhanced care, and care coordination. Based on these 8 change concepts, the participating provider readiness assessment criteria and tool was developed to select individual clinic and practice site locations to begin practice assessment, i.e. the PCMHA, negotiate contracts and practice transformation implementation work plans, and sponsor Medicaid transformation demonstrations. The selection criteria included volume, leadership, transparency, collaboration, adaptive, value-driven, and equity categories. The practice transformation work group reviewed and scored the selection criteria and attached weights for each criteria. Patrick Jones then took the results of scoring the selection criteria and assigned a weighted average to each category. The current state assessment related each question on the assessment to the selection criteria and then scored the CSAs based on the criteria and weights. Sam is now going to take you through her selection process and the results of the scoring.
Okay, are there any questions about the process that we went through before Sam does that? Okay, Sam.
Okay, great, thank you. So if we will pull up the document that's the selection criteria for participating providers, I'm briefly going to go through this document. So the different categories that were accepted by the project transformation team, as well as approved by the board previously, were volume, leadership, transparency, collaboration, adaptive, value-driven, and equity. You'll see that the different weighted categories are indicated on the very top, and then the total is at the end. This is a percentage of readiness that each one of these different entities had weighted towards them for each of these individual categories. This is not by any means a grade. It is based upon need in resources or resources available to be able to provide, or leadership in order for them to be able to accept the willingness for change in culture, for transparency, be able to guide us for data, for performance measures and benchmarking, collaboration to work together collectively as a team and a community, adaptive, again, that's going through those processes and quality improvement, and then value-driven to make sure that we are meeting the measures as far as for the Greater Columbia ACH, and then equity, making sure that we're looking at those patient populations and the diversity of those patients. If you look at the indications in red, those are exemplar clinics, and then indicated in yellow, the transformation project team, the facilitators can only do 22 clinics that we've really assessed as far as what we've looked at, estimated budget, as well as the time frame for this year. But that does not necessarily mean that we will not get to those clinics. We just estimate that it will be 2019 so we can get to those. But that also does not mean that we will not be able to provide resources for them. If you can pull up we're going to go through an example of how that scoring mechanism looks.
see, go over to, it'll say sample, it's all the way through. And then so indicated on the webinar, this is a sample of what that scoring criteria would look like. So on leadership, each one of these questions, can you go to the questions by category? Each one of these questions, that was on current state assessment survey were assigned to each one of these categories. So if you look at leadership, it had questions 6, 7, 8, 10, 11, 22, 23, 62, 63, 81, 82, and 85 assigned to them. Let's go back to the blind example. So on 6AA, and we're not going to go through this completely. I just kind of want to give you a sample of what that would look like. So project areas, bidirectional integration, these are mandatory. Any that were mandatory as far as like opioid management were assigned a value of 100%. If this particular entity had no desire to be able to participate in these different areas or project areas, they received a negative 100%. If they selected that they are going to participate in these mandatory areas, they received 100%. The other two were optional, and so they received a 50% value. So if we were looking at this example, this bidirectional integration, this entity chose not to participate in that particular project area. Is there any questions on that?
I think you're good.
Okay. Any questions on how we arrived at the different questions that were directly related to the survey?
Let me just ask, does the board, I think the board has seen this or a version of this grid before, right? We saw this a month or two ago.
Yeah.
Well, I'm trying to remember if this has come before the board or just the system practice transformation work group.
Transformation.
Yes, only practice transformation work group.
Yeah.
Okay, so for the board members that are not part of the practice transformation work group, this is kind of a lot of information. So I'm guessing that there might be some questions about this. So this is a primary agenda for today's meeting. So do you have questions about the formula, about the CSAs, assuming everyone has seen the CSAs and knowing that the information on this grid came off of those current state of activities applications? Do folks feel that they have enough information to see how this information came from those forms?
Rhonda, I do want to add that these entities were blindly evaluated and assigned these different weights. So the outcome was based upon the measures that were previously approved by the project transformation team as well as the board of directors.
Okay, good point.
So Rhonda, I'm sorry, this is Caitlin. I do have a question. I'm just trying to wrap my head around this again. So I apologize. Okay. So the categories that these providers were evaluated against were from the large assessment that they took, and then they were weighted. I guess I don't understand the process.
Yeah, well, I was kind of surprised by the lack of response. So thank you for speaking up, Caitlin. So Sam, it might be helpful just to back up a little bit because it's been a couple months since we went through this. So can you just back up a little bit and just walk us through from the beginning, sort of how we came up with the criteria and then how the CSAs drove this?
Yes. So originally what happened was we looked at the different areas of the guiding principles that the GCACH goes by, and it's these different categories here. The project transformation team, as well as the board of directors, voted on which categories were most important, and then Patrick at OHSU, Eastern, he actually took these different categories as they were voted and assigned a different weight to them. Once that was approved by the practice transformation project team as well as the board of directors, the CSA current state assessment was developed, and questions, individual questions, were assigned to each one of these categories.
And questions were intentionally put into the CSA that related to these categories or domains, so we would be able to do this sort of analysis.
And as part of that, the practice transformation work group went through an exercise to decide where the weighted value, how these different domains should be weighted, with collaboration being the most important, and followed by adaptivity, followed by collaboration and leadership being the most important. So that criteria and the weighting was determined by the 15 members of the practice transformation work group.
And so that's really helpful. It makes it make more sense to me. So then on the Excel sheet, there's the weight, and how does it all add up, and what is the adding up of the weights or the sort of percentages? Like some of them are 22, and what does that mean generally?
So it's just a tier level of readiness. The clinics that we will begin with, the 22 that we are evaluating for the year of 2018 for practice transformation.
Okay.
You're welcome.
Okay, that's super helpful.
And do you want to say anything about the OHSU grid on the right, Sam?
Sure. OHSU was an outside entity that we had also score. They based theirs up on different levels of the CSA, current state assessment, and it was more in regards to readiness of practice transformation in regards to the PCMH model.
It's also important to realize that when OHSU did their analysis, right afterwards, we decided to do a write-back process, or what we call minimum submission requirements. So for organizations that left important questions unanswered, we sent those CSAs back to those organizations and gave them a timeline of 2 weeks to complete them. Once the completed CSAs came back, Sam then rescored it using her criteria. So the OHSU responses were based on, in some cases, partially completed CSAs.
And so, Rhonda, I would point out that those people on the practice transformation work group, your scoring turned out a little bit different than this because it did not include the minimum submission requirement additions that we got, and we got a ton of them. If you recall, the practice transformation work group saw the grid that Wes had prepared that showed all of the different deficiencies and the lack of answers. So there were a lot of answers that we got returned from the second submission of the CSA. So it did change some of the scores.
About 44 organizations were requested to do the MSRs, the minimum submission requirements. So quite a few organizations were given the possibility of a write-back, or the opportunity.
And if I'm remembering correctly, the OHSU did not use the same scoring requirements or criteria that the Greater Columbia staff did based on the practice transformation work group, the domains that are at the top of this grid. Am I remembering that correctly?
Yes, Rhonda, you are correct. They went through the CSA and actually just looked at readiness and for PCMH model transformation and really calculated it based upon current efforts and their ability to be able to achieve the GCACH domain project areas.
Okay.
It's important to remember that these domains or category are key core change concepts that relate directly towards primary care medical home. And this whole exercise is to prioritize for practice transformation, which ties into primary care medical home population health management. So it doesn't mean that there's not other options.
This is Madeline. I just had a clarification. I just had a clarification in the process. You had mentioned that some of them were provided an opportunity to resubmit. Were there ones that weren't given that opportunity, and if so, why?
The opportunity to resubmit were based on the absence of information contained within the CSA. It was not based on us reviewing an answer and not liking the response. It was simply based on blank answers. So going through the CSAs, we looked for applications, and there was some selection based on the kind of organization. If an organization didn't, for example, select chronic care and prevention, if they didn't complete that section and they weren't going to do that project area, then we didn't see a reason for them to complete that section. But certainly around Project 2A, bidirectional integration, and Project 3A, opioid use, all those questions were required. Coordination of care questions were required. And the section under demographics, which had some very key free text questions around provider willingness and readiness, were required. Does that help, Madeline?
Yes, thank you very much.
Are there other questions, particularly for those board members who were not involved in the practice transformation work group and have not spent as much time with this grid and the process? Do you have other questions about how the process was designed and how it flows onto this selection of the 22 practices that would go into phase 1? Hearing none, I think we're hoping to be able to take action on this today. So if there is no additional questions, I am looking for a motion to either approve or disapprove the selection of the first 22 practices for practice transformation.
Rhonda, this is Darlene. I think that those of us that have organizations on this are going to have to abstain from this vote.
Well, we had that conversation at the last meeting, Darlene, and I think the consensus was that we had already approved the process before we knew what organizations were going to be affected. And because we're going to face this going forward with lots of different projects. And so the question is have we followed the process that was pre-approved, which basically before any names of anything was attached, we had developed and approved the process. And we're being true to that, basically. And so, you know, we could just as easily take the names off, take the column names off, but this is the process that was approved. We did discuss this at last month's meeting, and that's what the board had agreed to.
Okay, I will go ahead and move then.
And I'll second that move because I think that there was a lot of work that's gone into this, and I think that it looks fair.
Darlene first.
So that was Darlene, and that was a second. Was that Ronnie?
Yes.
Okay. And so we have a motion from Darlene to approve the tier selection for practice transformation and community partners, a second by Ronnie. And so let's open it up for discussion. Dan, was that you wanting to discuss?
No. Ed, was that you?
Does anyone have any comments?
The only comment that I would make is...
Go ahead.
Hi, Rhonda. The only thing that I would comment on is that I think that it was painstakingly done. It looks very fair. And I think that we've followed the process, and the outcome of that process is evident. And I think that going forward with this is definitely going to make some movement happen. And I think that in the future, as we go forward, we're going to see how well this works.
Okay, thank you. Any other comments?
So just as some additional information, Lauren took the is it the top 22, Lauren?
Yes.
The top 22 providers that are on the list and mapped it out in our mapping software to show that there's provider representation across all of or each of the 9 counties.
I would have to point out, though, this is Carol, that the Whitman Hospital, the Whitman Medical Group in this second iteration after we got back all the CSAs did not make it into the top 22. So that one dot that shows Whitman, I think that's the Whitman Medical Group. However, the Pullman Regional Hospital is in Whitman County. So we tried to show that there's geographic representation across the region as well.
And that just came out naturally from the scoring prior to the application of the scoring criteria. It's not like, I mean, we have made a commitment to do work in each of the counties, but this fell out naturally.
Okay, thank you. Any other comments or discussion before we call for the question? Okay, if not, then I'll call for the question. All those in favor of accepting the motion to approve the practice transformation selection of the first 22 practices, say aye.
Aye.
Is anyone opposed? Are there any abstentions?
Yeah, this is Caitlin. We're going to abstain.
Okay. Okay, well, the motion passes then. Thank you very much. Carol, that's the last thing on our agenda. Is there any other business that you want to discuss? We have a bit of time left.
There was the hospital sector board representation that you asked me to put on the agenda.
Yes.
Rhonda?
Yes.
Okay.
So, go ahead.
So on the face of the agenda itself, I cut and pasted the section from the bylaws that talks about midterm vacancies. I was notified on Monday by Russ Meyer, who is the CEO from Virginia Mason Memorial, that Jim Eberly is no longer with the organization, and he was our hospital sector representative. So Russ would like to nominate Shawnee Haas to replace Russ on the board of directors. And so Rhonda asked me to cut and paste the section from the bylaws that speaks to this. And I think that there may be a little bit of an interpretation issue here, but the way that it has worked in the past is that if there is a vacancy midterm, then that sector representative is responsible for getting their replacement. And so that's what Jim Eberly has apparently done, is to nominate his replacement, Shawnee Haas, and so that's what's coming in front of the board today. If this was a replacement that was outside of the midterm, it was like a regular replacement for the next 2 years, then that nomination would come in front of the board through the nominating committee. But for now, this is the way that we have been treating midterm replacements, so that this replacement would fulfill the term of Jim Eberly, which I think continues through 2020. Did you have the list of? And so I asked Lauren to produce the list of board members and their length of term. So she's bringing that up on the screen now, so you can see that. Scroll down to Jim Eberly. So you can see that Jim had selected it. Well, remember we had the lottery that selected the years of service. The hospital is a 2-year term for now, so that expires 1/20.
Okay, so if you'll go back to that agenda, Lauren, or to the agenda that has the bylaws, and I asked Carol to put this on the agenda because I wanted to make sure the board was comfortable. And as she said, she and I read this 2 different ways. I thought this read that it needed to go back to the sector to name the replacement as opposed to the outgoing member replacing them. So wanted to make sure that the board was comfortable having the outgoing member name his or her replacement. And if the board is comfortable with that, then we can move forward with bringing Shawnee onto the board. Or would you rather see this, or do you read this as saying that it should go back to the sector to name their replacement?
This is Sandra. I interpreted it the same way you did, Rhonda, where that it would go back to the sector. And I'm not necessarily opposed to either option. I just interpret it the same as you.
And this is Madeline. I also interpreted it that way. Madeline, again, have we had a past practice on this where we have had a replacement brought forward and voted on?
Yeah, so Jefferson Coulter had nominated Ronnie Batchelor to replace him on the board, Madeline, and so that's the way we handled his replacement. Although I have to say that there weren't a lot of consumer representatives within that sector that we could call on, unlike the federally qualified health centers. And I think that Martine did it a little bit differently. I didn't realize that Martine had gotten together with some of the other FQHCs to replace himself on the board. Although he was a total replacement, he wasn't a midterm, so he was going off the board.
I think when Eddie Miles stepped off the board, I think he named Jim Eberly to be his replacement. I don't think they went through the sector, did they?
Right. I think you're right. Eddie had suggested Jim to fill his position. I think, one of the biggest differences here is, although Signal Health is closely associated with Virginia Mason Memorial and does a lot of business with them, they're not necessarily a hospital, So I think that that's this recommendation that's coming from Virginia Mason Memorial should consider that.
Well, and again, this is Brian. I was actually thinking the same thing. Isn't Shawnee like the president of Signal Health? That's the Medicare replacement HMO thing, right?
They're integrated and care coordination organization.
But Signal Health is under the umbrella of Memorial Hospital, so you could. I mean, she is the executive director of Signal, but they are still under the umbrella of Memorial.
Right.
So that I mean that it's a good point. So this really is the question: is how does the board? What's the pleasure of the board? Would you like to see it go back to the sector, or are you comfortable with them naming their replacement?
I don't have a big problem with naming their replacement. I mean, the board needs to approve it, right? So it is going back to
Well, the board does, but I think it sounds like I think we're agreed we have done it both ways here now. And so in terms of what should our expectations be going forward? How would you like to see this here and going forward so that we're not being just specific to, yes.
I believe that it should be going back to the sector. That's my opinion.
And this is Madeline. Just to kind of clarify, when we say that it's going to go back to the sector, is that, so this is the hospital sector, so there is a process for the hospitals to convene and make a recommendation. I'm just wondering how that would occur.
Yeah, so what I would do, Madeline, this is Carol, I would go back to the hospitals that are in Greater Columbia ACH, try to gather them up to discuss who they want as their hospital representative. All of the hospitals have submitted LOIs through the LOI process, and so I would connect with them through whoever signed the LOI, and we would have a meeting to discuss their sector representative and then bring that forward to the nominating committee.
And we could try to do that before the next board meeting?
And I'm just I'm representing transportation, and so as I move off the board, how that next process would look just within my sector. So I think just having it clarified within some process to be able to identify how that recommendation would come forward from a different sector.
Right.
I think you make a really good point. When we started this process, it was more organic. It was collecting all the people that we knew that were part of sectors and getting them together. I think the hospital sector was a little different because I didn't make that recommendation. That one was from Blake Rose. However, I remember for the housing sector, we tried to collect all of the housing representatives together that we knew of and had a conversation on who should represent the housing sector on Greater Columbia ACH.
The housing sector had several calls.
Yes.
To get there. Mm-hmm.
Right.
So would somebody like to make a motion on how we move forward on this particular item? And I would say generically, not necessarily specific to Virginia Mason Memorial.
And this is Madeline. I would move that for replacing sector representatives, that the sector identify and make a recommendation to the board on the replacement.
This is Sandra. I'll second that.
Okay, thank you. Is there any further discussion?
Oh, so are you saying, Madeline, I'm sorry, I have a question. Are you saying that it wouldn't go back through the sector organizations? It would just simply be a recommendation of the representative that was on the board?
No. So that wasn't clear enough. So the replacement nomination would come from those representatives from that sector.
Okay.
So convene the sector again. And
All right.
I liked, oh, I'm sorry. So your idea of going back to the LOIs for the people that are on that sector was, I think, what she was saying, Carol.
Okay.
Okay. And the second was from
Sandra.
Sandra.
Go ahead, I'm sorry.
Thank you. Yeah, that's okay. Now it's open for discussion. So go ahead, Brian.
Well, I think that's what these bylaws notes actually do say, is that you go back to the sector. That's how I read this.
Okay.
So I mean, like I said before, I'm kind of comfortable either way, but I do think that it's most consistent with what we're trying to accomplish. So I like the motion as it is, as it was presented, going back to the sector.
Okay. Any additional comments or questions? Okay, then all in favor?
Aye.
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 Any opposed? Any abstentions? Okay. And you'll notify Virginia Mason and gather the sectors together, Carol?
Yes, I will.
Thank you very much. And then the last update we have is the Kittitas Digital Commons project. Wes?
So before we get into this, I just want to outline that at our September Leadership Council meeting and our September board meeting, we expect to have members of the what they call the A team from Kittitas County Health Network and Rob Arnold, the consultant we've hired to go through this process to talk about how the process unfolded. I'll probably make an introduction to it and then talk about their progress to date. So I'm just wondering, do we want to go through this discussion now and have it again in 2 months?
Can you just give us just a brief update on what the project is and what we're going to hear about in September?
Real briefly, as we know, back in January, we put out an RFP for a consultant to do some IT integration. After last year, we decided not to do Project 2B, the community-based care coordination. For a lot of reasons, we decided not to do that project, but a big reason was that it was specifically tied to the Pathways Community Hub, which at the time we felt was somewhat restricted, centralized, frankly expensive. And because of that, we opted out of Project 2B, but made a commitment towards care coordination in general. Care coordination is an essential piece of the primary care medical home. There's some information that calls out the 5 tenets or principles of PCMH, and coordination of care is one of them. And some documentation that I have, it talks about how the primary care medical home strives to build strong communication with patients among all members of a patient's care team, which includes both providers and community-based organizations. So in January, we put out an RFP for an IT integrator. Quickly, we chose Rob Arnold with Quad Partners. After that, we sent out a digital health commons use case application to individuals in the community who we thought were doing coordination of care work. I believe we sent it out to 4 or 5 organizations. 2 organizations responded. The organization that we eventually chose was Kittitas County. Rob's contract was signed soon after. And then we went into the project mode where he met with GCACH County. He's had several meetings with them. They speak very highly of Rob. Rob speaks very highly of them. And they've created a use case or a process of care around managing individuals with behavioral health needs. I actually have the current iteration of that use case. It's not yet finalized, but in general, the use case focuses on people with mental health issues who see a social service provider. Social service provider initiates an electronic referral with a built-in consent compliant with 42 CFR Part 2, which gets sent to the A team. The A team is essentially the triage organization where a central server is placed, and that client's information is entered into the server. The software they use includes Pre-Manage, which is something we're going to be using in practice transformation in other ways, and Strata Health, which is a very widely adopted EHR in Canada and soon to be in New Zealand and some other countries. Seems to be becoming very popular with single payer national health systems. So the social service organizations makes a referral to the A team. The A team then makes a determination about whether to send it off to the behavioral health provider, which in this case is comprehensive health care. If the A team decides not to send off the referral, they send off the contact information to the members, the client's primary care physician. If they're not sure about whether to make the referral, then they bring in their community paramedicine community, who does a site visit and a screening, including a social determinants of health screening, which includes questions around housing, employment, and some other areas. They feed that screening back to the A team. The A team then reassesses whether or not a referral needs to go to comprehensive mental health or behavioral health. And then if it's approved, then it goes on to comprehensive. And I'm going over that very lightly. There's a lot more detail in that. Again, they're very close to finalizing their final use case. So what's important here, and what really is the secret sauce, is not so much the IT integration that's customized to the use case, which in itself is very important, but what's also as important or more important is the collaboration that led to the development of this use case. And really this occupies about, I would say, 60 to 80% of the time. And in doing that, individuals, the organization, and entities within the network, including social service agencies, come together in a way where they systemize care. And this is part of what the Practice Transformation Group in our organization is doing. So the systemization of care, the designation of a specific workflow that they all agree to, and this is not easy work. Several iterations go into this. There's also a common language that's formed around a particular use case, and there are common metrics that are formed around the use case. So in a way, it's almost kind of like what we're doing with this collective impact approach with the Leadership Council. So this has been a real learning opportunity for me and for Carol and for the rest of the organization to understand how they do this work. And we now see how this adds a lot of value to creating these local health networks and how they form integrated care around particular patients. And the focus should be on individuals with high cost, high needs, high utilization, that 10 to 20% that eats up the vast majority of health costs. So we expect this to be a success. We expect the initiation of the first e-referral and the associated care plan to be initiated before the end of the year. That will complete the pilot project. From then on, the GCACH County Health Network is then responsible for operating the system and paying for the cost of the cloud server, which will maintain the database, which will again go through Pre-Manage and Strata Health. So it's a little complicated. That was very light on the use case. After that, we'll make a determination about whether to spread this to some other areas. At this point, I support it, not just from the care coordination integration piece, but again, the collaboration, the collective impact, and everything that goes along with it. This is really essential to coordination of care. And I'll stop there for questions.
Thank you, Wes. Are there any questions? Will this be live by the time when they come to do their demo and talk to us in September?
I don't know, Rhonda, because now once the collaboration use case development is done, then Rob goes out and gathers the IT components to build it up. I mentioned some of the individuals or the organizations or the vendors that will be involved, but there'll be more to it. There's the cloud storage piece and some other integrated issues that I'm not knowledgeable about right now. Whether or not they're able to initiate that first e-referral within 2 months, I'm not quite sure, but I will tell you that they're proceeding along very rapidly. Once the use case gets going, then setting up the rest should be pretty straightforward.
Although, Rhonda, I can say that they've successfully implemented this in Olympic Community of Health.
They have. And they've also done this Puget Sound Fire through what's called FD Cares. So this idea and this same IT integrator has been used elsewhere throughout the state. So there may be some opportunities domain one across other ACHs.
Interesting.
That's a real open-ended part of this.
Yeah. Are there questions for Wes? Okay, well, thank you. We'll look forward to that. Is there any other topics that board members would like to bring up or discuss today?
Yeah, this is Dan Ferguson, and I will be representing Greater Columbia ACH Workforce Committee and sending out a request for participation in the latest iteration of the Sentinel Network. So just be aware of the fact that you'll be getting kind of this, you may be getting requests to participate in the Sentinel Network, which is a workforce demand data gathering entity from the University of Washington Center for Health Workforce Studies. So look for that request.
Thank you, Dan. Anyone else? I do want to ask for any public comment as well from any of the guests that are on the call.
So Rhonda, this is Carol. I could just briefly update the board. Right now, the behavioral health providers are meeting as we speak to discuss the contract and the funding allocation. So we should have a better understanding this afternoon of where they're at, and we can address that.
So Carol, yeah, why don't we take just a minute and talk about what's happened since the last board meeting with the behavioral health providers? Could you do that?
So as the board might recall, we had tentatively approved a contract between the behavioral health providers and Greater Columbia ACH with a funding formula that they had received from the behavioral health organization. They got together after our board meeting to discuss the funding formula, and there have been 2 alternative funding formulas forwarded that they will be discussing today. I think before it comes to the board of directors, we want clarification on how that funding formula was arrived at. But otherwise, the behavioral health representatives are continuing to explore formulas that provide enough funding to get them into integrated managed care contracts and to be ready for integrated managed care by 2019. So there's been a tremendous amount of work done by Diane Halo, who is now the project manager for IMC, to get the providers ready. We have 3 groups that have been formed. All 3 of them have met. And so we're going down the road and acting basically as the convener for the providers, since the behavioral health organization did not want that responsibility.
Carol?
Yes.
I was out of town. I did receive an email from her, but I was out at training, so I wouldn't have been able to make that meeting. But there are ongoing meetings from what I understand in the email. But
yes.
I'll still be able
Yeah, Diane just told me that you're on the communications work group, right, Ronnie? And so you'll have a standing meeting as well, the provider readiness and the early warning system work group.
Correct. That's my understanding of it.
That's right.
Okay. And
So,
Dan, I look forward to the workforce.
Okay. So I think that the other clarification since the last board meeting, we had a discussion about the implementation funding for the BHO, on whether those were state-only funds or federal funding that we would be watching over. And we did receive clarification that those were federal funds. Carol did have the contract reviewed by our attorney, and so once we review and agree on the allocation formula for the BH providers, then it looks like the contract will be ready to go. And one of the things that we might want to do, and hopefully we'll do once we have a recommendation from the behavioral health providers, is have the staff person or the accounting person or somebody kind of walk us through the allocation recommendation so that the board has a good understanding of what we're being asked to approve, which as you just said, Carol, they had the original proposal that they shared with us last month, and then a couple of other alternatives were presented to them, and hopefully that they will come to some consensus on today. But we want to make sure that the board understands where these formulas are coming from, and we may want to have their accounting person come and present that to us and walk us through it, so we make sure that we understand what we're being asked to approve. Ultimately, the goal being that all of the substance use and mental health providers, behavioral health providers, are using the funds to assure their readiness for 2019. So with that, is there anything else for the good of the order before we adjourn? If not, I would call for a motion to adjourn.
This is Madeline. I make second.
Okay, all in favor?
Aye.
Aye.
Okay, well, thank you all. Have a great afternoon.
Thank
you.
you.
Thank
you. Bye. Bye.
Hi, this is Ashleen.